Good morning, my dear friends. Our topic for presentation today is skin and subcutaneous tissue. I myself is Dr. Arun Joseph P. Why are the diseases of skin and subcutaneous tissue important? Because the diseases of the skin, the patient can not only feel the disease, but the patient can also see the disease. In most of the other diseases, the patient can only feel the disease. Suppose your treatment is making an effect, the patient will know because the patient sees it. Suppose the treatment is not making an effect, again the patient will know and he will say that he is not a competent doctor. So, to know how to treat the diseases of the skin and subcutaneous tissue is very much important, because these are the diseases many a times brings about the competency of the doctor in front of the patient. In many other diseases we can use our tongue and decrease the disease, but not in case of the skin. In the skin you have to really treat the diseases and you have to bring about an effect, or else the patient is going to lose his confidence in you. Now let us come to the anatomy of the skin. The layers of the skin are the epidermis, the dermis and the hypodermis. You can see the epidermis, dermis and the hypodermis. Now coming to the closer to the epidermis, the layers of the epidermis are the stratum corneum, the stratum lucidum, the stratum granulosum, the stratum spinosum and the stratum basale. The stratum lucidum is generally seen in the palmoplantar area in the thick skin. After the epidermis comes the dermis. The dermis has a superficial part of papillary dermis and the deep part of the reticular dermis. The papillary dermis has papillary projections. The dermis has also the sebaceous glands, the sweat glands and the hair follicle. We can also see the erector pili muscle here. We can see a horizontal vascular layer in the junction between the papillary dermis and the reticular dermis. In the epidermal to papillary dermis connection, we can see the papillary projections of the papillary dermis and the projections of the epidermis towards the papillary dermis are called the retapex. So we have already said about the vascular channels here. This is the horizontal vascular connection between the epidermal and the papillary dermis layer. There is another vascular connection in the dermis between the hypodermis and the reticular dermis. These are the two horizontal connections between the hypodermis and the reticular dermis and the epidermodermal junction. Now there are vertical channels connecting between these layers of the between these two vascular layers. After that comes the hypodermis. Hypodermis is mainly composed of fat. The fat is divided into multiple septae. In between the septations there are many mast cells and many other immunological cells. The mast cells, the cells are either mast cells, and the cells can be fat lobules, can be a primary fat lobule or a secondary fat lobule. After we have dealt with the basic skin structure, now we will come to the inflammatory conditions of the skin. Before coming to the topic per se, we will contemplate a few sentences regarding this topic. This disease is distributed along the milk line. Autoimmune reaction in the skin after the intake of sulfonamides involving up to 20% of the total body surface, 20% of the total body surface area is called. When the above autoimmune reaction involves 40% of the total body surface area, it is called dash. The inflammatory conditions of the skin which we are going to discuss today are Hidradenitis suppurativa, PYODERMA gangrenosum, toxic epidermal necrolysis bar Stevens-Johnson syndrome. Coming to Hidradenitis suppurativa, it is a chronic inflammatory condition of the skin, and the patient presents with multiple abscesses, interconnecting sinus tracts and foul smelling discharge. As we see in this picture, the patient comes with the multiple scarring and multiple abscesses in the axilla. Many times, rather than the physical part of it, the high amount of recurrence rate and causes a high amount of psychological depressive state for the patient. Generally, hidradenitis suppurativa involves the skin of the axillary, inguinal, mammary, inframammary and perineal area. That is, it is distributed along the milk line. In the early stages, it can be treated with systemic and topical antibiotics. But when it involves multiple abscesses and scarring of the skin and multiple recurrences, in case of refractory cases, we will have to go for a surgical debridement, excision of the involved skin, whether it may be an axillary, inguinal or the inframammary area, and go for a skin grafting. Excision and skin grafting is preferred over excision and primary closure, because if we are going for a primary closure, many a times our excision part may not be complete and some amount of axillary and inguinal skin may remain, or rather the involved skin may remain, and what will happen? There is again a chance of recurrence after the excision and primary closure. So, skin grafting is preferred over excision and primary closure. Next is PYODERMA gangrenosum. We can see the picture of PYODERMA gangrenosum here. It is a non-infectious neutrophilic dermatosis. It is associated with inflammatory bowel disease, rheumatoid arthritis, hematological malignancies and monoclonal gammopathies. It is a relatively uncommon disease, so it is not that important, but the association with these syndromes which makes it much more common, much more important. It will initially start as sterile pustules which ulcerate into various depths and dimensions. Corticosteroids and immunosuppressive treatments are the mainstay, and surgical debridement is done whenever the wound mandates it. Next step, we come to toxic epidermal necrolysis or Stevens-Johnson syndrome. What is the importance of this disease? If you get a patient with toxic epidermal necrosis or Stevens-Johnson syndrome once in your life, you will always think before prescribing a drug. You will always have a fear before prescribing a treatment or a drug. It generally follows a prodromal period of upper respiratory tract infection. The signs are macular eruptions, blisters. Nikolsky sign is if you give a lateral pressure in the skin, the dermis and epidermis get separated, and a partial thickness skin injury. The clinical courses, it increases up to 7 to 10 days and resolves over a period of 1 to 3 weeks. It can be drug induced, generally aromatic anticonvulsants, sulfonamides, NSAIDs and allopurinol etc. are the inciting drugs. The treatment you have to treat, since it is a partial thickness injury, we will treat it like we treat burns. The wound care is exactly similar to burns. And systemic therapy, IVIG, intravenous immunoglobulins can also be used for the treatment as far as the systemic therapy is concerned. Toxic epidermal necrolysis and Stevens-Johnson syndrome. The clinical course, the inciting factors, the treatment, everything are same. Then how these are different? Depending upon the percentage of the body surface area involved, they are called by different names. When greater than 30% of the total body surface area is involved, it is called toxic epidermal necrolysis syndrome, and when it is less than total 10% of the total body surface area, it is called Stevens-Johnson syndrome, and in between 10 to 30%, it is called TENS SJS overlap syndrome. Now coming to questions regarding the inflammatory conditions of the skin. This disease is distributed along the milk line. Axilla, inguinal area, mammary area, inframammary area. Yes, it is Hidradenitis suppurativa. Autoimmune reaction in the skin after the intake of sulfonamides involving up to 20% of the total body surface area is called. Less than 10% it is called Stevens-Johnson syndrome. More than 30% it is called toxic epidermal necrolysis syndrome. So 20% is SJS tense overlap syndrome. When the above reaction involves the 40% of the total body surface area, it is called more than 30% tense syndrome. Now coming to the pretest on injuries to the skin. Which of the following ultraviolet rays has the highest propensity to cause malignancy on exposure? Ultraviolet A, B or C rays. The most common location for pressure sore is. For the next three questions, next three statements, you have to say whether it is true or false. Acid burns are generally superficial than alkali burns. True or false? Cardiac arrhythmia is the leading cause of death in hydrofluoric acid burns. True or false? Slow rewarming is preferred over rapid rewarming in frostbite. True or false? Injuries to the skin can be of different types. They can be radiation-induced injuries, trauma-induced injuries, caustic injury, which is caused by either an acid or an alkali or a chemical, thermal injuries, which are generally burns, and pressure injury, which bed sores are mainly come under these. Coming to radiation-induced skin injuries, the sun's radiations which reaches the earth's surface are the infrared rays. The infrared rays mainly deals with the heat part of the sun. Next comes the visible spectrum, which deals with the light part of the sun's radiations. But the radiation-induced injuries to the skin are mainly dealt by the ultraviolet rays. The ultraviolet rays include the UVA rays, the UVB rays, and the UVC rays. As we go from the UVA rays, the wavelength decreases and the energy increases. The UVB rays. Next, now the UVB rays. In case of the UVC rays, most of the UVC rays doesn't reach the surface of the earth because it is prevented by the ozone layer. The ozone hole can bring about the presence of UVC rays on the surface of the earth, which can be dangerous. We know that radiation can cause injuries, but who are the people who get these radiation-induced injuries? Let us have a word about tanning before we go into the further injuries. Tanning can be caused by radiation, both by the ultraviolet A radiation and the B radiations. But the tanning caused by the UVB radiations are more homogeneous, whereas the tanning caused by repeated UVA radiations are more long lasting. But nothing comes without a flip side to it. UVA radiations along with tanning can cause aging of the patient. So why can't we do it with the UVB radiation? UVB radiations cause burns. Sunburns are generally caused by UVB radiations. So UVA for aging, B for burns. Then what is C for? C is for cancer. UVC radiations generally produce malignancies. Fortunately, ozone layers prevents the UVC radiations from coming to the earth, but on exposure, UVC radiations has a high propensity of producing malignancy. Coming to trauma-induced injuries. Trauma-induced injuries are either mechanical injuries or bite wounds. All these trauma-induced injuries are a combination of penetrating trauma, blunt trauma and shear forces. Here you can see this picture. This part is the penetrating part. The depth is due to the penetrating part. You can see on the sides that there is contusion. It is due to the blunt part of it, and you can also see that the skin is being lateralized to both sides. That is due to the shearing force. Now, the penetrating part is mainly done with suturing. If the component is mainly the penetrating component, it is dealt with suturing. Suppose the blunt injury is the predominant component in the wound, the healing is by either a secondary intention, or we will wait and we will do wound debridement and then we will go for a delayed suturing. If the tangential component is the predominant thing, if it is a partial thickness injury like an abrasion, it will heal spontaneously. Suppose it is a full thickness injury like an avulsion wound, we will have to go for a skin grafting, either the avulsed skin itself or a split thickness grafting from another side. So the treatment of as far as the treatment of the wound is concerned, trauma-induced injuries are concerned, we will see whether the penetrating component or the blunt component or the tangential component, which is more predominant, or the combination or the different combinations of these components, and we will decide which type of intervention is better for it, whether it is suturing or healing by primary intention or grafting. Another type of wounds are the bite wounds. What is the importance of bite wounds? Unlike the other injuries, we will have to give an anaerobic coverage. There will be high chance for anaerobic infection to the high amount of anaerobic bacteria in the mouth of the human or other animals, for example dog bite, and we will have to give a cover for anaerobic infection. Caustic injuries are injuries which are caused by acids or alkalis. First up is acid injuries. Acid injuries has two components in it. There is a thermal component and a chemical component. The thermal component is due to the exothermic chemical reaction, and the chemical component is basically due to that chemical reaction. As there is a thermal component, there is coagulation necrosis, which results in a scar formation. This is a thick scar which is formed in the acid injuries. What will happen? Due to the scar, the acid will not be able to penetrate further, and this will result in a comparatively superficial injury when it is an acid injury. Next comes the alkaline injury. In case of an alkaline injury, there is only chemical reaction. There will not be any heat. The result is, due to the chemical reaction, there will be liquefactive necrosis and there will be no scar formation, and as a result the alkali can penetrate deep and it will result in a deep injury. So in the end of the day, even though acid injuries appears to be very tough, or acid injuries appears to be vitriol, you know that vitriol ash, putting acid on the face appears to be very bad, alkaline injuries are the injuries which causes deeper injuries and deeper tissue destruction. Whether it is alkali injury or acid injury, the treatment of caustic injury is to wash with plenty of water. For acid injuries, we will have to wash, acid burns we will have to wash for around 30 minutes, and for alkali burns we will have to wash the wound for up to 2 hours. The rest of the treatment are similar to that of burns. Hydrofluoride burns. They are a special category of caustic injury. How do a person get hydrofluoride burns, hydrofluoric acid burns? They generally get from burns from air conditioned cleaners and petroleum refineries. The fluoride ions binds to the calcium and magnesium, causing hypocalcemia and hypomagnesemia. What is the result? Hypocalcemia can result in cardiac arrhythmias, which result in the death of the patient with hydrofluoric acid burns. So generally the treatment includes plenty of calcium gluconate both topically and intravenously to decrease the systemic effects of fluoride resulting in hypocalcemia. Now coming to thermal injuries. When we speak about thermal injuries, we initially think about only burns. But along with burns, we have frostbite. Burns are caused when the temperature is on high, and the frostbite happens in case of freezing temperatures. We are not going to discuss a lot about burns in this presentation. We will discuss it in a later presentation. But one thing we have to know about burns, what we have to do. That is, in burns, there is a zone of coagulation which will be lost anyway in the skin, in the epidermis and the dermis. There will be a zone of coagulation which will be lost anyway. Then there is a zone of stasis and there is a zone of hyperemia. The zone of the hyperemia almost always returns into normal, but in the case of the zone of stasis, there is marginal perfusion. So we have to salvage the zone of stasis area or the zone of marginal perfusion area. That is our aim in case of burns. Now coming to frostbite. You see, the frostbite can be of different degrees. In case of a first degree frostbite, there will be only discoloration of the skin. Whereas in case of a second degree frostbite, some more deeper tissues are involved, especially the papillary dermis, the superficial layers of the dermis are involved. So there will be blisters and crater formation. In case of a third degree and fourth degree frostbites, deeper tissues are involved. The muscles, tendons and blood vessels freeze. There will be intracellular formation of ice. There will be formation of ice in the blood vessels. So what is the result? There will be decreased amount of perfusion to the affected tissue, which can even result in gangrene of the affected part, which will later fall off, and that is why it is called frostbite or a frost nip. Next is, how will we save the limb? When we have to warm the limb. So what happens? The ice melts. Once the ice starts melting, there will be intracellular accumulation of water and there will be capillary leakage. So in order to prevent the tissue damage, rapid this rewarming is done. Better is the result. Lesser is the tissue damage. So rapid rewarming to 40 to 42 degrees Celsius is done in order to decrease the tissue destruction in case of frostbite. Next up are the pressure injuries, and the most common manifestations of the pressure injuries which we usually see are the bed sores. The bed sores, the location are generally the ischial tuberosity, greater trochanter, sacrum and heel, of which ischial tuberosity is the commonest site for bed sores. There are different grades for bed sore. When we see a bed sore, we should try to grade it rather than just write bed sore and go. Grade 1 is a non-blanching erythema over the intact skin. When we see this, don't wait for the pressure sore to develop. Go buy a water bed, go buy an air bed and put the patient in that. Or else he or she is going to develop a full-blown pressure sore. Grade 2 is a partial thickness injury with blisters and craters. We can see a small blister which has ruptured and formed into a crater. Next comes the grade 3, which is a full thickness injury of the skin, but it does not involve the fascia. We can see a granulation tissue here. It is full thickness injury. Next step is the full thickness injury with destruction of muscle, bone, tendon and joint capsule. These types of injuries will require debridement and you will have to wait for the granulation tissue to develop, and at the end of the day we will have to go for a flap cover, which is a rotational advancement flap. Stage 2 ulcer will generally spontaneously heal. Stage 3 ulcer, stage 3 pressure sores may either spontaneously heal or will require a vacuum closure. And stage 4, of course, we have said it will require wound debridement and finally rotational advancement, flap car if it is in the gluteal region. Now coming to the post-test. Which of the following ultraviolet rays has the highest propensity
to cause malignancy on exposure? UV, A rays, B rays, C rays. A rays, aging rays, B rays, burn rays, C rays, cancer rays. So the answer is UVC rays. Most common location of pressure sore is, even though the pressure sore happens in sacrum, heel, ischial tuberosity, etc., the most common location is ischial tuberosity. Acid burns are generally superficial than alkali burns. True or false? In acid burns there is eschar formation, it is coagulative necrosis. In alkali burns it is liquefactive necrosis. So due to the eschar the acid cannot penetrate deeper. So acid burns are superficial than alkali burns. It is a true statement. Cardiac arrhythmia is the leading cause of death in hydrofluoric acid burns. True or false? Hydrofluoric acid burns, the fluorine can combine with calcium and magnesium resulting in hypocalcemia and finally cardiac arrhythmia. So cardiac arrhythmia is of course the leading cause of death in hydrofluoric acid burns, which is true. Slow rewarming is preferred over rapid rewarming in frostbite. True or false? In case of frostbite, during the thawing period, the maximum amount of tissue injury happens. So we have to decrease the thawing period to minimum. So rapid rewarming up to 40 to 40 degrees Celsius is preferred over slow rewarming in case of frostbite. So the statement is false. Rapid rewarming is preferred, not slow rewarming.